This is a technique video describing an isolated osteochondral autograft transplantation for a focal chondral defect of the patella. Shown here are the senior author's disclosures. The patient is placed in supine position on the operating table and induced under general anesthesia. An examination under anesthesia is performed to confirm the clinical findings. Anterolateral and anteromedial parapatellar portals are made, the arthroscope is inserted into the joint, and the knee is insufflated with normal saline. Suprapatellar pouch, lateral and medial gutters, and the cruciate ligaments are assessed. The root and ramp areas of the medial and lateral menisci are palpated with the probe to evaluate attachment areas. Attention is then brought to the chondral defect previously identified on the patella, and the size of the defect is approximated. A probe is used to establish the margins of the defect on the integrity of the cartilage, observing if any delamination is present. Defects of 10 to 12 millimeters are the upper size limit for OAT procedures. An anterior midline incision is made 6 centimeters proximal to the superior pole of the patella to just distal to the tibial tubercle. A medial parapatellar arthrotomy is then made, separating the vastus medialis oblique and the quadriceps tendon. The chondral defect of the patella is once again identified, and the diameter is calculated by measuring the margins both proximal to distal and medial to lateral. Once the extensor mechanism is isolated, a Z-retractor and a penetrating towel clip are used to retract the patella laterally in an everted position. Once the margins are delineated, a surgical marking pen is used to outline the borders to ensure all of the defective margins are resurfaced. The cartilage defect diameter is used to measure the size of the autograft transplant needed from a lesser articulating surface. Any remaining chondral flaps are removed, and a guide pin is placed at the center of the defect. This is then overreamed with an Autograft Oates recipient site reamer to a depth of 13 millimeters. Irrigation with cold saline may be used to avoid iatrogenic heat necrosis during reaming. A series of rongeurs, blades, pickups are used to remove the excess reaming fragments. Attention is now brought to the autograft harvest site on the superior lateral trochlear groove. The tube harvester is inserted perpendicular to the joint to avoid graft prominence. A 13 millimeter deep osteochondral plug is taken from the lesser articulating cartilage by malleting down the harvester to the desired depth. The harvester is then removed, alternating in turns of 90 degrees clockwise and counterclockwise while elevating until the autograft is completely removed. The guide pin at the center of the patella is removed, and suction is used one final time to remove any small loose bodies in the defect site. The tube harvester is placed in the debrided site and is slowly turned clockwise to deploy the plug into the patella. A towel and small impactor are then used to reduce any prominent portions of the osteochondral autograft into the recipient site until it's flush with the patellar cartilage margins. The medial arthrotomy is then closed using number 2 non-absorbable sutures. Confirmation of smooth patellar tracking is validated one final time prior to closure. The remaining deep tissues are closed with O and 2 ovecral, followed by a monocrystal stitch for the skin.